Everyone. Welcome to our live online webinars. Today we have webinar number 22, Comprehensive Neuroanatomy Educational Program. And we will have our chairperson, Professor Dr. Muhammad Usman. He is the head of Neurosurgery Department, PAF Hospital, Islamabad in Pakistan, and Vice President, Pakistan Society of Neurosurgeons. Our first speaker is going to be Professor Mehmet Zileli, Professor of Neurosurgery, Sankara University, Gaziantep, Turkey, Honorary President of the Middle East Spine Society, past President of the World Spine Column Society, Turkish Neurosurgical Society, and Asian Pacific Spine Society. Professor Mehmet Zileli will be talking about when spine fusion is necessary in understanding the indications, options, and the benefits. And the second speaker is going to be Dr. Adnan Khalik. Dr. Adnan is the assistant professor of the Department of Neurosurgery, Swat Medical Complex Teaching Hospital in Swat, Pakistan. He will be talking about spinal dysraphisms, diagnosis, classifications, and management. Thank you.
It's my great pleasure to be with you. I find these series of webinars very useful and very beneficial for young neurosurgeons. And this time, although it is mainly anatomical subjects, this time I will talk on a clinical subject. When spine fusion is necessary, one of the most hot topic of spinal surgery. And the question is, lumbar spine stenosis, shall we decompass it, or if necessary, when to make a fusion? I will start with an anatomical landmark that there is a motion segment, so-called motion segment. This is a 3 parts of anatomy of spine. One is a disc. It is not a real joint. It is an absorption point of the body weights. And 2 facet joints is the 3 joint complex. And this motion segment can degenerate by the time. It's a normal aging process. And there are mainly 3 phases of it. One is the dysfunctional phase, then unstable phase, and stabilization phase. And this progression of degeneration starts with dysfunctional phase. In this phase, we don't need to make surgical decisions, surgical management. Then unstable phase, some cases may need a surgery. Then the rest stabilization phase, we don't need to make any fusion surgery at that phase. We can make just decompressive surgeries. And lumbar spinal stenosis, in the dysfunctional phase, there is a soft stenosis. Then in unstable phase, a dynamic stenosis. Then in the rest stabilization phase, there is a hard stenosis with hypertrophy of facets and ligamentum flavum. And surgical indications are mostly just neurogenic claudication, more than 95% of the patients. Absolute indication of cauda-equina syndrome is a very occasional, it's not common. And surgical techniques, mainly 2 techniques, one decompression only, the other one is decompression and fusion. And there are different techniques of decompression and fusion. The fact is that probably we are offering too much surgeries to those elderly population. we are doing too much instrumented fusions, which then result with complications. It may be up to 25%, and we need to analyze and revise our surgical results with these two facts. And our spine committee, WFNS spine committee, has developed some recommendations, and you can look at them. And there are many others as well, but lumbar spine stenosis decompressions are here on that website. And if you look at the natural history of the disease, approximately 30% of patients are expected to worsen, but 30% may improve with conservative measures, and the remaining 30% stay stable. They do not change their symptoms. There are predictive signs and symptoms that they will worsen. Dural sac cross-sectional area, if it is less than 50 millimeters square, presence of radicular symptoms and back pain, presence of degenerative listhesis and or scoliosis, and if the symptom duration is more than 1 year. And unfortunately, there is no correlation between clinical symptoms or function with the presence of anatomic narrowing of the canal on MR, CT, or myelo CT. And radiological instability criteria, there are many criteria, but the most important one is probably the functional radiograms on flexion and extension standing X-rays. But in addition, in MR especially, modic changes, end plate edema, extended discal vacuum or air inside the disc, traction spurs, synovial cyst, annular tears, listhesis, or facet fluid sign, like you see in this axial image. There are additional indirect signs of instability. Many people ask for neurophysiology, EMG, or evoked potentials. Unfortunately, there is no diagnostic value of electrophysiologic tests for lumbar spine stenosis. They do not predict outcomes as well. And there are many non-operative treatment and operative treatment options. And non-operative treatments may be physical therapy, especially exercises, epidural injections, some painkillers, lifestyle modification, and weight reduction for obese patients. What about fusion? How to select patients for surgery? We must first apply conservative therapies and physical therapy and make injections. Then, if they don't work, then we can recommend some surgeries. And for these recommendations, we have to have concerns about the comorbidities, age of the patient's psychosocial status, and patient expectations as well. There are mainly two types of stabilization. One is the fixation and fusion. The other one is dynamic fixation. I will not talk about dynamic fixation, and I do not believe that they have benefits over fusion surgery. What about fusion surgery? There are many non-instrument fusion, which we used to do many years before. Nowadays, many surgeons do not prefer it. Instrumented fusions, mostly with microsurgical fixation, but then the grafts can be placed on posterolateral or interbody. This is so-called wheelchair approach that you can make two incisions and then place your grafts on the transverse processes and the facet joints, lateral part of the lumbar spine. If you look at the advantages and disadvantages, non-instrumented posterolateral fusion is easy to apply, no implants, less bleeding. Instrumented fusion is easy to apply. The instrumented interbody fusion achieves sagittal balance, often foraminal narrowing by height increase of the disc space. So, however, disadvantages are fusion rate is somewhat less with non-instrumented fusion, 75 to 80% in instrumented posterolateral fusion. However, it is 90-95% in instrumented interbody fusion. Even some cases with instrumented interbody fusion may have non-union. Instrument fixation. Why do we add fixation implants during surgery? Why? They enhances fusion rate, they confers immediate stability, and the pain relief is immediate after surgery, and restores alignment. Sometimes there is also some imbalance of sagittal or coronal alignment. So then we can restore it. As I mentioned before, interbody fusion, the body bone grafts are placed between the disc space. Fusion is achieved at the center of the motion segment. If curated, this space is very vascular, promotes a solid fusion, and normal disc height is preserved, and normal sagittal alignment is achieved. This case is one of my older previous cases that I have done in one-level instrument fusion and bone graft only, no cage inside. In the past, we used to do PAT cages, so-called threaded cages, cylindrical shape. We were placing them even standalone. Then we have seen some instrument failures, then we left it by the time. Spine surgery has a really big involvement by the time because by learning mistakes of bad results of our surgeries. This is again another case with graft only, one graft only, solid fusion in 1 year. There are many types of interbody fusion. Posterior lumbar interbody fusion, transforaminal lumbar interbody fusion, anterior lumbar interbody fusion, or extreme lateral interbody fusion. So we don't want to call it now this way. We prefer to say a transpsoatic approach. But there is another option is the olive oblique lateral interbody fusion. Posterior lumbar interbody fusion has disadvantages of retraction injury to the nervus. So many people have left it by the time. And this technique was first used in the literature by Glowart, by placing iliac bone grafts by just pushing the cauda equina and after curating this space, placing 3 iliac crest grafts. And as I said before, treated BAT cages, then mesh parts cages have been used, peak cages have been used. Current trend is to use carbon-coated peak cages or carbon cages only. This is a case of BAT cages. After 2 months of application, they have went back and make a compression to the root, and we have to revise it with instrumented fusion. This is 25 years before one of my cases. Belief with bone graft and pedicle screw is an option, but currently many surgeons prefer transforaminal lumbar interbody fusion by removing one-sided facet totally, and then by seeing both exiting and traversing roots and placing the cage in between two roots. So then no root retraction is necessary. Then you can place a banana-shaped cage or two cages like you can see here. After placing the cage in the middle of the disc space or ventral part of the disc space, then some compression will help to achieve a solid fusion. This is a typical case with a peak and graft. So then I use a sandwich type of TLIF application. First place some grafts in ventrally, then cage. Then on the back part of the cage, I place grafts again. So it's not enough to place the grafts only inside the cage. You must also place the cage in front of the grafts in front of the cage and on the back of the cage. You can make this surgery by minimally invasive techniques, a tube-guided surgery. You can place a 24 millimeter diameter tube, and you can make it on both sides or on one side only. What about ALIF? ALIF is a surgery which can be done by an access surgeon, an abdominal surgeon, or if you are familiar with the anatomy, you can make it yourself. Then you make a retroperitoneal dissection, and for L5S1 or L45, L5S1, you must work in between the two iliac artery and vein for L5S1. However, for L45, you must retract the iliac artery, and most surgeons prefer left-sided approach because it's the only retraction is with the iliac artery instead of vein, which is more vulnerable to traction. Autonomic nerves, we must also be very cautious, especially in male patients, to preserve superior hypogastric plexus. Otherwise, a retrograde ejaculation may happen as a complication of this approach. We must be careful for complication if there is osteoporosis, previous disc space infection, spondylitic diseases, and two-level approaches. For L5S1 level, since the graft extrusion after application of a cage is possible, then there are so-called ALIF plate or cage with screws to make it a secure placement. What about direct lateral fusion or XLIF or transpsoriatic approach? We will prefer to use this term instead of the other, and it was first described by a Brazilian surgeon, Dr. Pimenta, Luis Pimenta, in 2003. Main advantage of this is a large cage may be inserted, provides stability. A large fusion bed is possible. However, there are some disadvantages. EMG monitoring is necessary because lumbosacral plexus is on the back side or inside the psoas muscle, and you can make an injury to lumbosacral plexus. Another thing is the indirect decompression of spinal stenosis is more possible with this technique, and even in some cases you can restore scoliotic curves by coming from the convex side. As I mentioned before, because of injury to lumbosacral plexus, we need to make an EMG monitoring. And since it's a very bulky muscle and more vulnerable nerves going to the ventral part of the femoral area, so some surgeons do not apply at L4-5 level. It's not possible to make it in the L5S1 level. I will try to describe that technique axially for L5S1 by coming from hiatus, sacral hiatus, and retraction of the bowels, rectum, from backwards, and then entering S1, then L5 bodies, and make some removal of the L5S1 disc, and then placing a so-called large cage here, a threaded cage. However, standalone usage is not recommended, and you must either even use pedicle screws or facet screws additionally. Need additional posterior fixation since it has high non-union rate and reported major complications, bowel penetration exactly. This technique was left by most surgeons, and it has disappeared from current practices of spine surgery. So, in general saying, complications of this surgery is about 10%. However, fusion surgery is about 20%. And most of them are implant-related, screw malposition, loosening, breakage, non-union, adjacent level disease. And for those reasons, MIS pedicle screw fixation may be an option. To make it possible, you need to make a good fluorescence or CT navigation, mostly by AP views, and tapping over the key wires, and you need cannulated screws, and placing a rod may be more difficult, so then so-called rod inserters have been used. The first one was developed by Dr. Kevin Foley, Sexton system. It has many advantages, especially preserving the muscles around the lumbar spine, which are very important. They have a big contribution to stability of the back. However, you have potential longer operation times and more radiation for surgeons. Probably navigation techniques must be evolved more than today's techniques. I will show you some cases. This case had a neurogenic education and anteflexion posture in walking, and we have done a one-level decompression and fusion using Philip grafts, local bone chips, and these are the films after 1 year with solid fusion. So, in the interbody fusion has more fusion rates. However, you must spend more times than other postural fusion techniques, and you must be careful to remove most of the soft tissues inside the disc and make some curettage of of the disc space, the end place. This is a two-level problems, and we have done two-level fusion surgery with TLIF. This case had again two-level problems with two levels TLIF surgery. In conclusions, post-rotator grafting plus pedicle screws may still be a good option. Interbody fusion provides better fusion rates, decompress the foraminal height, provides better lordosis. TLIF has more advantages than FLIF, ALIF, and XLIF, and axial lift has been abandoned in the literature. Thank you for listening.
So thank you very much for the great talk. Indeed, very important details we got today. If anyone has questions and comments, please. And from audience, you can also put your questions to the chat.
Yes, I would like to make a few comments, suggestions, and then a question. First of all, I would like to congratulate Dr. Ahmed for arranging such a wonderful and nice series of webinars. I think these are not only important for young neurosurgeons, and this was our concept that these are important for young neurosurgeons, but I must say these are not only for young neurosurgeons, but also for the senior and practicing neurosurgeons. Why I'm saying this? Because of the fact that when you are doing or you are practicing something and when you see the work of other institute, I think you learn few important things by the experience of that very neurosurgeon. So it is a great effort by Dr. Ahmed for arranging such wonderful webinars. Now I will talk about today's topic. I think spine fusion nowadays, it is a very contemporary and debatable topic. Why? Because when we see the literature, in the literature of last couple of decades, there is tremendous rise in the number of fusions all over the world. But having said that, are we convinced that in each and every case the fusion is necessary or not? So this is a very debatable topic, and I think there is no one else besides Professor Mehmet Zileli to talk on this very important topic, who is the global spine educator who helped different neurosurgeons. If I talk about Pakistan, he used to come to Pakistan in different workshops, webinars, and symposiums. He is actually a regular member of Karachi Spine, which is a global event held every year or after a couple of years in Karachi, hosted by our senior neurosurgeon, Professor Salman Sharif. So we used to meet Professor Zileli a lot, and we grew up, I must say, by seeing his talks and his participation in different spine courses. So I think he's the best mentor for this topic. I have a few comments that each and every case of spine instability should be individualized. We should keep in mind the motion preservation. Motion preservation is very much important. And when we see the RCTs, randomized control trials all over the world, so there is debate of arthroplasty in cervical spine a lot. So there are some certain absolute indications of spinal fusion, especially in lumbosacral spine, and I think these are the post-traumatic, the spondylolisthesis, the tumor-related instability. But there is no role of fusion or fixation in cases of only axial back pain, which is not associated with instability. So in such cases, I think one must go for the other options, which Professor Zileli nicely mentioned, the conservative treatment in the form of medications, the lifestyle modifications, and then the proper rehab schedule and rehab physiotherapy and things like that. So each and every case should be properly individualized. And I think now the world is moving towards uh, indication-centered approach instead of procedure-centered approach. You are well aware or you are familiar with the procedure, you are able to do the procedure. This is not a big thing. But when to do that specific procedure in your patient, this is the big decision which you have to take. So these are my few comments as a chairperson of this webinar. Now I humbly request Professor Mehmet Zileli. I will ask his experience on two things. The first thing which I would like to ask is about the for example, if a patient is having L4, L5 instability in the form of spondylolisthesis. So some surgeons prefer to include S1 as well in the fixation. So what is your take on that? This is my question number one. And question number two, when there are patients of multiple level spinal stenosis associated with degenerative early kyphoscoliosis. So how you manage these cases?
Many thanks, Dr. Mohammed, for nice comments and your concerns about too many fusion surgeries done by many spine surgeons. And we are also trying to make more indication-related studies instead of technical studies. I mean, there's another issue that currently many surgeons are trying to be more, trying to have more education on endoscopic techniques or technical surgical technique evolution, but they don't care about the indications too much. And another point is that patient-based decision making, we must evolve it. We must try to make more studies by placing the patient in the center of the decision making instead of dictating some indications to the patient. Because if they are not aware of the source of their pains, and we can have difficulties, and we must have too much caution not to make surgery of the films, instead surgery of the patient. Another concern is dynamic fixation, like cervical arthroplasty. There are also dynamic fixation of the lumbar spine or lumbar arthroplasty, which is not that much common as in the cervical spine, but arthroplasty is an issue that was mostly dictated to us by the industry, and their advantages are not that much high, I believe, than they say, and even some literature says. We must have too much concerns, and in order to decrease the complication rate of fusion surgeries, we must have shorter fixations as much as possible. But if we are doing deformity corrections, especially in adults, that you were telling about the kyphosis or scoliosis cases, we will have more concerns about the patient's bone quality, osteoporosis, patient's comorbidities, because they may have too many other diseases, whether the patient is smoking, cigarette smoking, or some diseases like endocrinologic diseases or rheumatologic diseases. We must be very cautious for planning long fixations and long fixation and fusion surgeries in adult patients. I don't know if it is the answer to your questions.
Yeah. Thank you very much. Thank you very much for the detailed elaboration and answering the question. One last question. I was talking about if a patient is having L4, L5 spondylolisthesis, for example. So some surgeons include S1 as well in the fusion and fixation. What is your take on that?
It's not correct if the L5S1 level is not too much degenerative. If there is no listhesis at that level, we must not include L5S1 as well. And the non-union rate of L5S1 fusions are quite higher than other levels. And we must have too much concern not to add S1 to our fixation points.
Okay, thank you.
Another thing I must tell you that there is a so-called stable listhesis. Some degenerative listhesis cases, as I mentioned, in degeneration phases of the motion segment, maybe in the stabilization phase. So they do not need to make any fusion surgery. I mean, you see a 4 or 5 degenerative listhesis, but there is no movement there, and the patient has no back pain, and the disc height is decreased. Those cases can go just a decompensative surgery.
Okay, thank you. Now, anyone want to ask question or comment, suggestion? The house is open.
Has here a question in the chat, Dr. Aidarus Ali. He's asking, in patients with disc herniation or degenerations in resource-limited areas, that we do only laminectomy and discectomy, and we do posterior spinal fusions without posterior spinal instrumentation without fusions. What do you think about that, Professor Muhammad?
This is not good. Yeah, I would expect the question to be asked. We do spinal fusion without instrumentation. Yeah. Why? The name of the surgery is fusion surgery. If you don't place graft properly, even posterolateral side, which has more non-union rates, or interbody, which has less non-union rate, you are not finishing your surgery. How come in a poor country you make a fusion surgery without placing any graft? Grafts, mostly I take from the body, the patient himself, not allograft or no cost. Autografts do not have any additional cost.
You know, Doctor, here in our country, we do usually fixation, posterior fixation, and the bone we take from laminectomy, we put in the transverse process on both sides.
Right.
As
this
graft.
is good.
Yes, this is not much good, but it's better than nothing. But
You're right. Right.
some surgeons they do fixation and they don't do fusion. They don't remember that
Yeah.
fixation is only to allow fusion to occur, to increase fusion rate.
You know,
So if you
right.
don't put a fusion graft, there is no point.
No. And actually, the fate of such patients are like this. At the beginning, they have good pain relief after surgery. If there were real instability at that level, and the surgeon has done a short fixation, let's say, and postoperative, the patient is very happy. However, after 3 to 6 months, since there is no fusion, it doesn't start a fusion. So the screws get loosened, and they will have then more back pain than ever. And most of these patients become more painful after 3 to 6 months than before surgery. This is a catastrophe. This is a big failure. If you
Yes,
don't achieve a good solid fusion, your surgery will fail always.
I have also, Doctor, another questions, if I have. As Dr. Muhammad Osman said, if in cases if we have L4, L5 spondylolisthesis, and some surgeons actually they do include S1, but in case if I have one level L4, L5 spondylolisthesis, and in additional I have S5, L5, S1, there is disc prolapse and degenerative changes, but there is no instability at that time. Should I include it in the fixation, or I can only do it in L4, L5 only?
I would rather do L4, L5 only. If there is, if you have done additional laminectomy for L5, S1, if there is listhesis over there or severe modic changes, you can add L5, S1 as well. But if not, try not to involve L5, S1 as well. It is not good thing.
Okay, thank you. Dr. Aidarus, I think he want to participate in the discussion. I will try to unmute him.
Thank you. Thanks a lot for nice invitation.
Thank you. It's an honor for us, Professor.
Hi, thank you, Prof. Can I explain my question, please?
Okay, go ahead, Dr. Aidarus.
Thank you. So my question was, in resource limited areas, if you can do only laminectomy, discectomy, foraminotomy, with applying your bone fragments over the, without using interbody catch or fusionist, but still we are applying the bone fragments on the spinals on the transfer process. So do you think that is enough? Because we are not using catch, we are not using anything in between the vertebral bodies.
And you don't use any implant. Do you mean this? No pedicle screw fixation. Did you mean that you didn't use any fixation with the pedicle screws? Do you mean this,
I think
Dr. Ali?
I think he mean that we do fixation, but he don't use interbody fusion. He only do bone graft in the spinous transverse process, like we do.
Okay, this is possible. As I mentioned in my talk, the solid fusion rate is somewhat less than interbody fusion. Interbody fusion has 90-95% fusion rate, interbody grafts. However, posterolateral grafts has 70-75% fusion rate. But if you are placing posterolateral grafts, you must use a handful of grafts. Too much grafts you must place there. And you, before placing the grafts, you must always decorticate the bone over there on the transverse process and also lateral parts of the facet joints. This is good. This is acceptable. No
Thank
problem.
you. My other question, can I ask again? Sorry.
Yes, go ahead.
It depends on the moderator.
Okay. So again, another question, Prof. So for sometimes if we do multiple fixations like L3, 4, 4, 5, so at that moment, is it possible or do you recommend to now to add L5 because we have multiple fixations above L5 S1? So at that time, do you recommend to add S1?
Okay. As I told before, try to make as shorter as possible fixations. However, if it is a deformity, like if there is a flat back syndrome or kyphosis, you may need to make longer fixations. Or if it is a degenerative scoliosis, you may need to make longer fixations. But then you must take concerns about the patient's bone quality, osteoporosis, and comorbidities, because longer fixations will need more bleeding, and you will then transfer blood, and then complication rate is somewhat higher. If it is real longer fixation, 4 levels or more, then complication rates are up to 45%. You must tell the patients that half of those surgeries will have some complications. If you are honest and telling this is okay.
Thank you.
I think there are
Thank
no
you so
more
much. Yeah, no
further
more
questions.
questions.
Yeah. Dr. Nargiza, I think we should move towards our next speaker.
Next speaker. Yes.